Hello everybody, Alena Skálová. I have two cases. The first one is a consult case from parotid gland, and I'm showing you scanning magnification first to show that it's a parotid gland tumor with a well circumscribed, relatively encapsulated but multinodular tumor, which is pretty monophasic. The major structures are trabecular with high magnification, a little bit of tubular differentiation, maybe here. Here, and there is a prominent myxoid, not mixochondroid, myxoid stroma in the tumor. So this is almost everywhere the same structure. Yeah. Maybe a little bit high magnification in more cellular areas to show you that the tumor is composed of one cell type, and the cells are quite regular, monomorphic. The tumor is a consult case of a 46-year-old female patient, parotid gland. Regarding immunoprofile, the tumor was positive for SOX10 and S100 and CK7. I can find it at the moment. Give me time. Yeah. So the staining is very strong for SOX10 in all cells. This is not biphasic tumor. So? I'm sorry, that was control case, but the staining is even better than in control. Yeah? So you can see that all the cells are nicely positive in the nuclei. The tumor is a SOX10 and S100 PRO10 positive, and it was completely negative for P63 and P14. Because of the tumor came as a possible pleomorphic adenoma, we did BLAC1, which was completely negative, but this is staining for the second possible marker of this type of tumor, and this is HMGA2. So it's diffusely positive in all cells, as you can see. Proliferative activity is pretty low, maximum 5%. And now, if you can show the paper, diagnosis is pleomorphic adenoma, but special variant, and we have recently had a paper in 2019, something with Abbas Agaimi. That was the first description. We coined the name adenoma, Canalicular adenoma-like tumor or pleomorphic adenoma. And in this paper, which I'm showing now, we present expanding spectrum of molecular and also histological findings. How can I move by the myši and kolečkem. Okay, I would like just to show you this is possible to plus to show it better. Sorry, I'm not so handy with the mouse. Yes, so you can see that the structure is pretty much the same, at least in parts of the tumor. This was very nice example. These tumors sometimes may have component of conventional pleomorphic adenoma, but not always, and some of these tumors do have only this canalicular-like structure, and these cases are quite often sent as consult cases. So I repeat again, the name is not very well settled, but in WHO classification now it's like variant HMGA. 2 positive variant subtype of pleomorphic adenoma with canalicular adenoma-like pattern. So that's current name. So that's my first case, and then we have you can remove it. One more case, which is also consult case, so quite straightforward. It's the diagnosis. The tumor is a parotid gland tumor of a 44-year-old male, and it was sent as a pleomorphic adenoma, maybe myoepithelioma, and you can see that the tumor is, you can't see that it was large, but it was quite large, and it's lobulated in the structure. The structure is like postulated, or what's the name? Multilobular, quite cellular tumor, and you can appreciate that certain foci represent necrosis, so there are necrotic foci. Atypical mitosis are not there, but the tumor is quite cellular. Little bit spindling can be seen here and there, but pretty epithelioid. Well, so differential diagnosis is between myoepithelioma benign and myoepithelial carcinoma. And we did also immunostaining, which supports diagnosis, both of them. It's a PLAG1 positive. For this case, I do not have immuno, but it was SOX10 positive, S100 positive, and PLAG1 positive. And diagnosis of myoepithelial carcinoma low grade was coined or signed out based on lobulated growth pattern, also invasive growth pattern, and these multiple necrotic foci. So myoepithelial carcinoma, pleomorphic adenoma, low grade, parotid gland of relatively young man. So that's my presentation, and I'm happy to pass it to someone else.
Is there any moment when we would call it high grade?
High grade would be, yes, good question. High grade would be if there are atypical mitosis, many mitotic figures. There is a suggestion of grading of myoepithelial carcinomas based on 2 criteria, mitotic count plus necrosis. Necrosis is one feature, and that was relatively low in proliferation and no atypical mitosis. So I believe that's a low grade, but definitely malignant.
Hi everyone, Marián Švajdler here. I will actually continue with some head and neck pathology. And this is a biopsy from quite a young lady, and it was a biopsy from the mouth, from the buccal mucosa near the orificium of the parotid gland duct, and you can see this. Actually, it's quite easy biopsy, but there is some kind of differential diagnosis here. And at the first moment, I was like enthusiastic about whether it is this recently described salivary gland carcinoma called microsecretory carcinoma. Adenocarcinoma. But very important differential diagnosis is, of course, adenoid cystic carcinoma, very classical, very common lesion. So we can perform, of course, our immunohistochemistry, and the tumor proved to be biphasic. So this is P63 in the outer layer of cells, and the tumor shows also some CK7 positivity, and I've performed MIP staining, MYB staining, and although it's quite sensitive, it's not entirely specific, so we always, or let's say not always, but especially when we get this differential diagnosis, we have to confirm by molecular studies, because adenoid cystic carcinoma is quite indolent, but in the long term aggressive and deadly cancer. So I have performed genetics, and it came back with very classical MIP and FIP rearrangement, the most common type. So my diagnosis is adenoid cystic carcinoma, probably from parotid gland infiltrating through the duct into the oral mucosa. So, but I don't know the follow-up of the patient.
I would only add, if it's can you hear it if I speak from here? I would only add that it's not indolent tumor, it's 100% almost killing the patient. It's a very, very important diagnosis, and I have seen in Marián's case small eosinophilic ductal structures which are diagnostic, but otherwise that structure was not very typical. You like to see cribriform structures, this was difficult case.
Okay, the next case, it's essentially it's quite easy. It's a young male patient, and it's a biopsy from his finger on the hand. I don't know the finger, which finger it was, but important clinical history. He's a guitar player. And yeah, it's in this case it's quite important, because this is it. Okay, this is a biopsy. He had some swelling on his finger, which was painful, and we can see why it was painful, because we see these Pacinian bodies, but these are not normal, are more numerous and are bigger, are edematous, and we can see also some fibroproliferative changes around the small nerves, and the lesion is called Pacinian neuroma. Okay, so it's not.
Don't play guitar.
Now probably he's fine, because excision is curative in these cases, and he can continue with his guitar playing. So this is Pacinian neuroma. It's not very frequent lesion, but you should have it in your differential diagnosis. And the clinical scenario is very typical. Okay, painful finger lesion in guitar players or violin players or whatever players. Okay. Yeah. Another case. Again, it's very basic pathology. It's a skin excision. It's a young, still quite young lady. You can see the skin surface here, and some spindle cell proliferation. Importantly, it's going down deep, and in some parts it was here going into the subcutaneous fatty tissue, and this lesion is composed of this eosinophilic, mildly atypical proliferation with lots of mitotic figures, and I believe there was necrosis present. We can see it. Here are the foci of necrosis. So when the morphology is clearly smooth muscle, okay, confirmed by immunohistochemistry, if you wish, desmin, actin, H-caldesmon, and if the lesion was not going deep into the subcutaneous tissue, the diagnosis can be atypical intradermal smooth muscle neoplasm, but if you've got lesion like this going deep into the subcutaneous tissue, you have to call it well differentiated Leiomyosarcoma. Okay, so this was my diagnosis at the end, Leiomyosarcoma. The next case, is not that common. It's coming from the hypophysis region. This case is quite interesting because most of the tissue was composed of this gliosis, some fibrous changes with some ghost cells, even some calcification and metaplastic calcification, and metaplastic fatty tissue was present there. The lesion is here. It's composed of this stratified epithelium with this whirling, these nests. The diagnosis is Adamantinous craniopharyngioma, and there are two types of craniopharyngiomas. Adamantinous craniopharyngioma, they bear mutations in beta-catenin gene, and there is papillary type, which is more common in adult patient, and these tumors have BRAF mutations. So if you are not sure, in this case, you may be completely sure with the diagnosis of Adamantinous craniopharyngioma. You can perform immunohistochemistry, and traditionally we used to do beta-catenin staining, and of course it's positive on membranes of these epithelial cells, but also shows aberrant nuclear expression in these nodular structures, which is quite difficult to see sometimes. So I have tried for the first time LEF1 antibody instead of beta-catenin in this case, and this is why I brought the case, because it's much easier to find these solid whirling foci having this nice nuclear expression. So LEF1 antibody is better compared to beta-catenin. And this holds true even in other indications, let's say for fibromatosis and other tumor types, if you wish to prove it's beta-catenin VNT pathway activated lesion. So this is very, very nice. So not all cells in craniopharyngiomas are beta-catenin altered, only these whirling solid nests are positive. This is another head and neck case. It's a child with a maxillar lesion. So this is easy. Yeah? It's reminiscing of normal tooth formation, but it's not. It's a tumor, and it's called Odontoma. But still, it's quite well organized tissue. It's really recapitulating development of the normal tooth. So in this case, it's called compound type. In contrast, complex type of odontoma, it's more haphazard tissue. So you can see this dentin. Most of the enamellum tissue is dissolved by when the tissue is prepared for histology, so you cannot find it there. And sometimes you can find even this amyloblastic epithelium, and it's present somewhere here, but it's really small focus here. So Odontoma. I see only maybe 2 or 3 cases every year. So
I have seen one last week.
okay,
Quite
it's
recently.
not very common in my practice. That's
Yes,
why I
yes.
brought it here. So okay. Another case, it's I believe older lady, 76-year-old, and it's a biopsy from mediastinum, and they send it with diagnosis. I don't know what it is, okay, but at the end it's very easy. You can see this blue cell something. In higher magnification, you can see it's small, primitive lymphocytes, right? So could it be lymphoma? Yes, we are in the mediastinum, but what should we do? We should do, of course, keratin stains. So this is cocktail staining. It's not very nice, but you can see this meshwork of epithelial cells in the background. In addition, using TDT antibody, you can confirm that indeed these are TDT positive primitive lymphoblastic cells. So it's not lymphoma, it's not carcinoma, it's Thymoma, right? And the typing based on small biopsy is always difficult, but in this case, I believe it can be typed as B2 Thymoma. So no undifferentiated malignancy, but Thymoma. You should have it in your differential diagnosis always when dealing with lesions from the mediastinum. My next case is again some head and neck pathology, and it's quite interesting. And at the beginning, it was misdiagnosed or not diagnosed correctly. Well, maybe I will show you the biopsy from the last November last year. It's a middle-aged lady with a clinical history of sinonasal squamous cell carcinoma. And now she's got a lesion in her orbit. So it came tumor of the orbit, and that's it, with no further clinical informations. And one of our colleagues had the biopsy, and she performed keratins, which were negative, and she signed it out, fibrous tissue, blah, 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 some cartilage present, no tumor there. But if you think about it, what kind of cartilage is present in the orbit, okay, or in the facial bones? Okay, facial bones are formed by these membranaceous bone formation. There is no cartilage stage. The bone is formed directly from this stromal fibrous cells, not from the cartilage. And moreover, this cartilage looks a little bit atypical in my eyes. So it's a little bit cellular, maybe some discrete hyperchromasia, maybe some two B-nucleated cells were present, and even if the tissue here is quite damaged, there is some kind of hyperchromasia. So if it was in my hands, I would ask for more tissue, okay? And after, let's say, 4 months, I had another biopsy. Again, it came with the diagnosis tumor of the orbit. And you can see some mucosa here. And under the epithelium, again, you can see this atypical looking cartilage. And next to it, you can see this atypical spindle cell proliferation with quite a high mitotic activity, and I was able to find even some atypical mitotic figures. Okay. And in another block, we start seeing this pinkish stuff here. So it's osteoid present there. Again, these cells surrounding these osteoid are quite atypical looking. Yeah. And if you wish, it's not really necessary, but I've performed SAT-B2 staining. And stromal cells and positive for SAT-B2. So my diagnosis is Chondroblastic osteosarcoma, probably post-radiation. Okay, so the lady received radiotherapy for her squamous cell carcinoma some 10 or 15 years ago, and now by radiology she's got base of the skull completely destroyed by tumorous growth in anterior and middle fossa of the skull of the base, and the roof of the orbit is destroyed by these tumors. So this is probably radiation induced or secondary chondroblastic osteosarcoma. So the prognosis is clearly very bad for this lady. Okay, look at another soft tissue case, quite interesting. Again, it came as a consultation, and this older lady had a tumor in S1, S2 segments of the vertebral column. So some probably bone was destroyed, and you can see this necrotic tumorous mass showing this morphology. And this is basically H&E diagnosis. You can see clearly adipocytic differentiation. The cells are very pleomorphic, bizarre, atypical, with lots of mitotic figures, necrosis. So basically only one differential diagnosis is the differentiated liposarcoma with homologous differentiated component. So you can have the differentiated liposarcoma with pleomorphic liposarcoma-like component, but in this case MDM2 immunostaining was negative, and the diagnosis is pleomorphic liposarcoma. So it's not very common diagnosis, and then it may occur in the retroperitoneum. By the way, the case came with the diagnosis, please rule out chondroma. So in my eyes, it's not possible. Another case is head and neck soft tissue pathology. This is a case of middle-aged female, and she had a tumor in nasal cavity. You can see this respiratory epithelium. It is completely normal, no dysplasia, and underneath the epithelium there is this fascicular spindle cell proliferation. And the cells are not that atypical. It's hard to find mitotic figures, but there are some. But there are not too many. And we are in a sinonasal region, and there is one particular lesion quite common present there. Although the entity is still quite new, but I believe we've got maybe 20 cases right now here in our department. And the clue to the diagnosis is, of course, immunohistochemistry, and the lesion is diffusely positive for S100 protein. Okay, that's positivity, and it will show also staining for some muscle markers, including rhabdo markers. So in this case, I believe it was MyoD1 focally positive. The expression is not very diffuse, but yeah, it's there. Okay, so some cells are positive. So we've got S100 and myogenic markers, and the tumor must be phenotypic sinonasal sarcoma.
Great. You have fusion?
Yeah, and I've got classical fusion involving PAX3 and MAML3 genes, so this is the most common situation. Okay, so there are some variants for that.
But it's not so common. You said that it's very common.
No.
Well,
It's but it's not that uncommon. Okay, if we deal with spindle cell lesions in head and neck area, many tumors will eventually end this with these diagnoses. Of course, there are other possibilities, including spindle cell variant of Rhabdomyosarcoma. And I believe that this biphenotypic sinonasal sarcoma probably has something to do with rhabdomyosarcomas as well. So it's probably some kind of low-grade rhabdomyosarcomatous type of lesion. And I believe there are cases described that differentiated into like straightforward rhabdomyosarcomas right now. So we've got, as I said, maybe 15 or something like cases.
Well, for many years we had two cases. For many years, for many years we saw the two cases, and now we see it all the time.
Yeah.
And there is a paper written by Michal Jr. and Natalka with malignant transformation to rhabdomyosarcoma.
Yeah.
Natalia is the first one, or you are? Submitters, the others. But it's quite recent paper, very good one.
Files,
May I have a H&E to put it
Sure.
to Sbírky?
It's already there. Yeah.
Okay, I'll ask you later.
My next case is very classical pancreatic biopsy. I see quite a lot of them, and age is not that important. I saw some lesion. Importantly, it's near the tail of the pancreas. It's almost always there, and you can see these normal pancreatic structures here. And I have already several times showed you the lesion here on the microscope, and the lesion is here. Okay, it's a consult case. So does anyone want to try with an H&E? So it's some kind of lymphoid tissue there, maybe with some sinusoids, which can be nicely highlighted by CD8 staining. So we've got CD8 positive sinusoidal structures there, and it's accessory spleen. Okay. So I had probably 5 or 6 cases last year, and in consultation people don't think about that. Looking at the biopsies from the pancreas.
So diagnosis?
Accessory spleen.
Maybe that's it from my side.
Good afternoon. Here's Květa Michalová speaking. I have two cases for you. The first one is quite a peculiar case, and the patient was a 19-year-old woman who had a tumor of the ovary in 2022, which was diagnosed and correctly diagnosed. We revised that it was a mixed germ cell tumor. And it was composed from embryonal carcinoma, dysgerminoma, teratoma, and yolk-sac tumor. I'm not showing you this biopsy. I'm showing you the following biopsy, which was this year. It was sent to us as a consult, and here we see the left ovary. So in the right ovary there was a mixed germ cell tumor, and in the left ovary is this. So this kind of malignant proliferation. The same neoplastic infiltration was seen in omentum and also fallopian tube on the left side. So I think that from the I'll show you some images first. So, because the previous diagnosis was a germ cell tumor, the SAL4 was performed to confirm or exclude the germ cell nature of the neoplastic proliferation, this SAL4 being negative, so it was not germ cell proliferation. I think that from the morphology is quite easy to estimate the kind of the tumor. This is ERK. And this is CD31. To find the lesion, here is the lesion.
What is it?
Sorry?
What is it, Iman?
This is CD31.
Yeah.
So ERK positive and CD31 positive. So we are looking at Angiosarcoma of left ovary, of omentum, and of fallopian tube, which it would be very rare. So as a primary tumor of the ovary, it is possible. But regarding the anamnesis of the patient, that she had 3 years ago mixed germ cell tumor composed of mainly composed of 4 components of germ cell tumors, mainly of yolk-sac tumor, and it was treated by chemotherapy. The possibility is that this has something in common with the previous diagnosis of germ cell tumor. And I ask Patrick for the PDF. And I'm not sure if this diagnosis was correct, but my thought was that there are primary extragonadal germ cell tumors of non-seminomatous character, which occur in male patients in mediastinum, and especially from the yolk-sac tumor here in mediastinum of non-seminomatous tumor of male patients can be sometimes transformed in so-called vasculogenic mesenchymal tumor, and it is described after chemotherapy for the primer germ cell tumor. And this vasculogenic mesenchymal tumor has a spectrum. It can be quite bland. That's why it is not called Angiosarcoma in all of the cases. The higher probability is that it will be more bland, like you can see at these pictures. It can be also transformed into more high grade, but still vasculogenic mesenchymal tumors not fulfilling the diagnostic criteria of angiosarcoma. But it can also be an angiosarcoma in rare cases. And I think this is what probably happened here in this patient, because she had yolk sac tumor in the primary biopsy, which is a original germ cell tumor being treated by chemotherapy. It can be transformed into sarcomatoid yolk sac tumor and also into this so-called vasculogenic mesenchymal tumor. It is not known or not properly investigated why this is happening only in extragonadal germ cell tumor of the mediastinum in male patients. It has not been described in ovary or also in primary testicular tumors in men, but it might be possible if this can happen in mediastinum, why not in ovary? And the reason for that is that yolk sac tumor has an ability to create vasculogenic stroma, and the sarcomatoid yolk sac tumor is the tumor where the stroma predominates, and this vasculogenic mesenchymal tumor is the tumor where the vasculogenic, this luminal component, this endothelial component predominates. So in male patients, the germ cell origin was confirmed by the presence of amplification of chromosome 12p. We performed molecular genetics to this case. It was not here, but in general, the amplification of 12p is much more common in male patients than in female patients. So this does not exclude the diagnosis. The amplification of 12p chromosome in female patients occur approximately in 30% of the patients. But still, this is rather hypothesis. So if somebody has a better opinion, better idea what this might be, I'll be glad to hear it. So this is the first quite complicated case. So the final diagnosis is Angiosarcoma in the ovary, arising probably as a consequence of yolk sac tumor treated by chemotherapy. And my second case is also a tumor of the ovary, also a young patient, 17-year-old, and we have a tumor here. Here we can see solid areas of overtly malignant tumor. Quite distinct areas here are these pseudofollicles. The main differential diagnosis, I would say, here, if we leave out germ cell tumor, this is not germ cell tumor. If we leave this out, is juvenile granulosa cell tumor or the hypercalcemic small cell carcinoma of the ovary of hypercalcemic type. So we can resolve this easily by immunohistochemistry. Here is SF1, which was negative, so it is not juvenile granulosa cell tumor and sex cord tumor of any type.
Smart.
Yeah, it is. I don't have. I couldn't found nowhere the slide of SMARC A4 immunohistochemistry, but it was lost. So this was a confirmation that this is a small cell carcinoma of hypercalcemic type. It was also confirmed by molecular genetics, because there was a confirmation of mutation of SMARCA4, which was a germinal mutation.
Did you have mucinous glands in it?
No, there was no mucinous glands.
I never saw it, but they write it. It may appear, but I never saw them.
Maybe they are somewhere, but they are not described in the histological.
If you would find some, you should show me, and I will lose my virginity.
I will show you. I'll show you then, but they are not here.
So what did you say? SMARCA for?
SMARC A4 lost,
Yes.
accompanied by SMARC A4
Okay,
mutation
fine.
of germinal origin. And I would ask Patrick for the picture. And
As I said, very rarely you can see even mucinous glands there. We have over 20, 30 cases of it, but we don't have a single case of mucinous glands. Yeah.
no,
That's
there
it.
were no mucinous glands as well. And one of the reasons I'm showing you this case is that according to the recent research, and especially thanks to the methylation profiling, it has been revealed that there are three different epigenetic clusters of this small cell carcinoma of the ovary hypercalcemic type. They have different gene expressions, also a slightly different morphology, and it can show us that this is rather according to epigenetic features, heterogeneous group of neoplasms, and this research might have an impact for the treatment options for the patient. For example, one of the clusters out of these three clusters has a larger amount of immune cells, and it might help for some treatment options. And also this particular patient, this case is quite old. It was diagnosed 2022, and I had a phone call recently from the clinician, and she told me, please revise the diagnosis because the patient is alive and well, and so I revised, you know about that, right? So I revised the diagnosis, and it was the diagnosis is correct, but it might mean that not every small cell carcinoma of hypercalcemic type will behave like we previously thought. And also the clinician told me that the patient was very well responding to immunotherapy, so it might fit this new observations.
So SNF complex deficiency in any kind of tumor may be a marker of better response to immune checkpoint inhibition.
So some rare cases can even survive for a long time. Does it correspond to some of these clusters in methylation profiling?
We didn't do methylation profiling,
This paper.
but there was a larger copy number variant in the better surviving group, so we might add this examination because it has been done.
We should do it, yeah?
Yeah, sure.
Patriku, pošleme ten.
So that's all from my side. Thank you.
It's Michael Jr., Michael McNall. I'll conclude with few more cases. This was a 70-year-old female, tumor in the wall of the duodenum. And this is the scanning magnification. You can see the mucosa at the bottom. The mucosa was ulcerated, but otherwise unremarkable. And the respective tumor basically infiltrated the whole thickness of the intestinal wall. And if you go a little bit higher power, you can see quite pleomorphic epithelioid cells, which in some areas especially have kind of like a nested arrangement. It's not really perfect, but in some areas I think this could be called a nested growth. In others, it was more kind of like a solid proliferation. Despite this pretty marked nuclear atypia, there wasn't that many mitoses. There was some mitotic activity, but it wasn't super high as you would maybe expect based on the pleomorphism. And the cells, for me at least, they have kind of like this neuroendocrine appearance. So based on IHC, so there was a broad panel done, cytokeratins were negative. Then there was S100 protein, it was diffusely positive. in this tumor. This is the submitters S100. You can see some parts of the cells are more strongly positive than the rest, than the cytoplasm, but still overall it feels like a diffuse expression, especially in these areas. If you do SOX10, it's perhaps more useful, more obvious where the expression is. You can see this very fine dot-like expression. Then we did chromogranin, which is basically 100% of cells are positive for chromogranin, and INSM1, also diffusely positive. So this already goes in the direction of, anybody has a guess?
Paraganglioma.
Yes, paraganglioma or pheochromocytoma, we don't know the location actually. And this is GATA3, which is positive in the vast majority of paragangliomas / pheochromocytomas. So basically this patient has to staging, we have to find out where is the location, probably might go from the adrenals actually. And the last crucial stain here is SDHB, because it could be a familial paraganglioma, pheochromocytoma, it's retained, so it's basically excluded. How much more time do I have? 7 minutes. Okay, so I usually show here cases we all show here cases which we successfully diagnosed. So I'll show here one case where I screwed up. So this was a 23-year-old girl with a 5 centimeter cervical polyp, which was sent in for consultation. And this is what we saw. So there were large areas of necrosis. Maybe I'll start with the scanning magnification again. So here is the base, and here seems to be the surface. And there's a lot of necrosis, but it feels like it's on the surface, so I thought it might be basically a traumatic necrosis, because the rest of the lesion looks like this. It's kind of hypocellular, very bland. Even when I went through it retrospectively, I was not able to find more than one mitosis per 10 high power fields. So no atypia for me, or minimal. The only worrisome feature for me, which I remember, this is a case from November last year. So here you can see how it kind of infiltrates in the smooth muscle of the uterus, which was worrisome, but we showed it to a couple colleagues and we didn't have a name for it. We did comprehensive molecular profiling, DNA, RNA sequencing with like the broadest panel we have, everything came back negative. All immunohistochemistry, smooth muscle markers, S100, CD34, everything was negative. So I'll show one more slide. So again, you can perhaps better see here the infiltrative nature of the tumor. Here is the smooth muscle and the penetration of the tumor in it. And here perhaps a little bit more cellular areas, but again, no overt atypia, no mitotic activity. I was also wondering whether this could be like some just reparative changes after some trauma, but it was weird. It was a 5 centimeter polyp, but we just didn't know how to call it. Every molecular was negative, so we called it descriptively, potentially mesenchymal or probably mesenchymal tumor. We don't see any features of malignancy, but we don't know what it is. So basically, we said follow the patient carefully. And about 1 month ago, I received another material from the girl, and this was from the uterus, posterior uterine wall. So here is some endometrium, myometrium, and then you have here this little piece, which it's diagnostically even harder, but you can see it looks identical to the uterine, to the cervical lesion. So this is already alarming, because you have something that looks benign in the cervix, but the same benign looking tumor in the other side of the uterus. So this I became alarmed and started to think really hard what I missed. And eventually, again, I did like 15 immunostains, everything was negative, but then finally I thought about doing the crucial stain. Anybody has? Yeah, yes, Marián knows it already. So this is B-core stain.
B-core.
And this is B-core staining. This is positive in all the tumor cells. So this is something I should have done, but because we did like the comprehensive molecular profiling and everything came back negative, I thought B-core is excluded. The problem is that there exists one variant of B-core sarcoma of the uterus, which is not caused by fusions or by fusions, but by internal tandem duplications, which are not picked up by our main sarcoma panel, or our main solid tumor panel. So we had to use basically an Archer panel for lymphomas to confirm the mutation. So this is again, I'm getting back to the first sample from the cervix. This is cyclin D1. Cyclin D1 is also positive in most B-core sarcomas. It's not specific at all, but it's very sensitive, so it can kind of help as well. So also the diffuse nuclear expression and B-core expression here in the first cervical sample, also diffusely positive. So this is B-core internal tandem duplication in a uterine, high-grade uterine sarcoma. So I call the clinicians, I send an email to as quickly as possible operate the girl, because first time we didn't know what it is. She's 23-year-old, she's probably wanting to have kids, so we were very careful, but now it's of course a red flag, and she must undergo hysterectomy and staging and everything.
I think cyclin D1 is a good marker to like screen for the tumor.
Yes.
And I showed you the very much the same looking case few weeks ago, and it was a little bit myxoid, very low grade looking, but still it's very, very aggressive, and it should be called high grade.
Exactly. The clinicians actually called me like 2 days later, and they were like, but in the first biopsy you said it's bland, benign looking, so is it high grade sarcoma now? I was like, here the molecular just trumps everything.
So this is really scary tumor.
These tumors are notoriously bland looking. I just forgot about them and didn't realize we don't have covered internal tandem duplications. So last case, so not to finish with... Yeah, so not as in order not to finish with my total failure, I'll finish with this case. 13-year-old boy, tumor in the subcutis, like 1 centimeter something. And here, as always, very important to start on low power. Low power is crucial source of information. Here, what we will find on low power are these lymphoid aggregates at the periphery. So many that you can wonder whether this is lymph node with metastasis. And then you have here this varicellular tumor. And what is important, you also have here this kind of like cavernous space filled with blood. If you go on higher power, the tumor cells, some of them at least, have this formicoid characteristic nuclear features. Sometimes you have to look for them, but whenever I see lymphoid aggregates at the periphery and some blood-filled spaces, I go for it. Perhaps here, these kind of clear looking or optically empty nuclei with kind of like histiocytoid features. Here again. So I was thinking whether this could be angiomatoid fibrous histiocytoma. The name is horrible because it has nothing to do with normal fibrous histiocytoma. So we have benign fibrous histiocytoma, aneurysmal fibrous histiocytoma, and all other variants of fibrous histiocytoma. But then there is so-called angiomatoid fibrous histiocytoma, and that is completely different tumor with EWSR1 rearrangements, typically EWSR1 ATF1. So first I did some IHC. It can be sometimes very helpful. You can try EMA. EMA is usually positive, not always, but some 60-70% of cases are positive. Here it was negative, only some probably plasma cells were positive. Then useful might be Desmin, which is positive in about the same number of cases on 70%. Here we have nice expression of desmin. It's rarely so diffuse. And then there is a more recently described helpful antibody, which is ALK. And this tumor is commonly ALK positive despite absence of ALK fusions. So it can help. Then I did just EWSR1 fish, and this is confirmed angiomatoid fibrous osteosarcoma, typical for young patients, especially boys. And it's a low-grade sarcoma, which may metastasize in few percent of cases, but rarely leads to death of the patient. Here again, last thing to show, this HN is a little bit better. This optically empty nuclei with osteocytoid features. Okay, that's all from us, and see you, hear you next week.